Good evening, friends, and welcome back to the Thursday evening teaching sessions being brought to you from LTMMC Sion Hospital, Mumbai. We once again thank the authorities at Sion Hospital for allowing us to conduct these clinics and for Alchem Alpha Max division for giving a scientific grant to relay these clinics all over. Our case today is being presented by Dr. Ashish from Sion Hospital.
Good evening, all and present. This is a case of a Shahnawaz patient, 60-year-old male child, second by birth order, born of a non-consanguineous marriage, resident and hailing from Dhaka, Bihar, Muslim by religion. History is given by mother, reliable source. Child presented with complaint of generalized swelling all over the body since 15 days and fever since 1 day. Child was apparently alright 15 days back when child develops swelling initially over eyes, followed by both lower limb up to the knee and distension of abdomen later involving the genital area, uh, not associated with decreased urine output. 7 days later, child developed fever, which was acute on onset, moderate grade, intermittent. Child was active in interfebrile period. Fever was relieved by medication, non-associated with chills or rigors, and not associated with abdomen pain, rash over the skin. And for these complaints, child was taken to the private practitioners, where child received some medication, but symptoms was not relieved. Child do have history of a similar episode in past, three similar episode in past. First of which happened in September 2019, 3.5 year back, when child developed fever followed by swelling around eyes and abdominal distension. Started on some medication for 3 months. After during this course, swelling got relieved, and similar episode happened. Second episode happened on June 2020, with similar complaints, and for which child was treated on OPD basis. Third episode happened in July 21, for which child was admitted for 2 days, and initially IV medication were given, which was later shifted to oral medications. So negative history: no history of cola colored urine, no history of headache, blurring of vision, no history of headache or altered sensorium or seizure, no history of pain in abdomen, vomiting, reduced appetite, loose stools or cough, or no any respiratory complaints, no history of crying during menstruation, urgency or increased frequency of menstruation, no history of congestive cardiac failure or acute liver failure, no skin lesion, no rashes or joint pain, no inappropriate weight gain or abdominal pain, generalized weakness and body ache was present, no history of cox or cox contact. Moving on to antenatal history, it was spontaneous conception, and the antenatal period was uneventful, no history of any complaints. Birth was full-term normal vaginal delivery, uneventful, not requiring any NICU stay. Child was unimmunized at birth. On dietary history, it was taken by 24-hour recall method. Child was adequate on calories and proteins, eat from family pot, and have salt in food in form of like pickles and papad. Coming to development history, child is appropriate for age, achieved all milestone is appropriate age, and there is no significant family history. Parents belong to upper lower socioeconomic class. This is the pedigree of the family. The firstborn child was died due to pneumonia at 3 months of age.
So, how will you analyze the presenting complaints without taking into consideration the past history? What are your thoughts?
Child has generalized swelling all over the body, more of like anasarca. So it is no other significant, just we have fever of 1 day with swelling of 15 days. So it may be of cardiac or hepatic origin or renal origin. We have to further see any past history of similar complaints.
So the point is that we should try to learn to decide what it is without recurrent past attacks. Okay, if it becomes past attacks, it becomes easy. So now try and differentiate between cardiac and liver, which you said.
So generalized swelling has three differentials: hepatic, cardiac, and renal origin, and nutritional in early onset. So renal will start in the periorbital region first, then lower limbs, and then anasarca. Hepatic will start in the abdomen, progress to the lower limbs, and then to the entire body. Whereas cardiac will first start in the lower limbs, then ascend upwards. So these are the differentials of generalized swelling.
Okay, so you're right, but now we should get deeper into this. So can a child with liver disease not come to you with edema feet?
They can
Come. So you said that it starts with the abdomen. You're right, but a liver disease child can also come to you with edema feet. So it could start in the, for the patient complaint, it could start in the legs, right? So what else do you want to know to differentiate between these three?
So when child comes with a liver disease, it will be associated with some many other symptoms. So we can ask for illness and some loss of weight, and child would be sick looking child, and we can with any irregularities in urine or urination and discoloration of skin, some rash, and some other symptom like hematemesis is going on there.
Very good. And what about cardiac?
So in cardiac also, first thing is child will be having different progression of swelling. And swelling would be a later part. We will see in a later part, and some other side like respiratory complaints will be we will see before the swelling, and the tachycardia will be there, tachypnea will be there.
Very good. So actually in all three, cardiac, liver, and even in malnutrition or protein losing enteropathy, there will be some clinical symptomatology after which there will be swelling. Whereas in this kind of a situation, swelling seems to be the first manifestation. The child is well before that, right? So that is one. Now we have discussed this many times, but we'll repeat it. Why does this renal edema start in the periorbital region? Why other edemas don't start there?
In periorbital region, loose irregular connective tissue, and in renal origin, there is hypoalbuminemia. So, in every edema, there is hypoalbuminemia with changes in oncotic and osmotic pressure, hydrostatic pressure. But because of loose irregular tissue in the periorbital region, first we usually notice in the periorbital region, and more during morning times.
Correct. So this reduced oncotic pressure and increased hydrostatic pressure is present in every edema, you said, right? And you're right, it is there to some extent in any edema. So then why loose areolar tissue only in renal? Loose areolar tissue is there in even in the person who has liver disease, no? So what is the other factor?
Sir, just salt due to salt retention, the osmotic pressure. The liver won't have that much of salt retention.
Of course,
And,
liver has salt retention.
and,
See, wherever there is extravasation of fluid, because the intravascular compartment starts getting theoretically compromised, everything will get activated and salt retention will happen. So, salt and water is retained in liver disease also. So, in the wards, have you seen puffiness of eyes anytime? When have you seen? Yeah, but when? Morning means all 30 children in the ward have puffiness in the morning? Fluid overload. So that fluid overload happens in how much time? So that is the answer. So whenever there is a sudden onset of that fluid accumulation, then it finds that loose areolar tissue first, and that's why you see it. So in the other causes, the reason is chronic. It is not sudden, right?
I think if you look at what has been put up here, we don't know where the edema started, we don't know how the child was, and we just take that. So you would say that this is an acute onset, generalized, fastly progressive edema. Okay, now acute onset is always of two types, acute on chronic or only acute. If it is acute on chronic, could it be malnutrition? Well, he has a subclinical malnutrition. He is low in proteins, but something that triggered made him worst. So would you consider acute onset malnutrition in this child? Typically, you see this in a child who gets 1 day loose stools and comes up with edema and the whole kwashiorkor. So kwashiorkor is an acute onset disease on chronic. Could this be that?
Other stigmata of nutrient deficiencies, micronutrient deficiencies, if they're present, along with this, maybe
You're
we
right.
can suspect.
So you want some symptoms prior to that, but there could be a no symptomatic infection. Okay, he's just losing appetite, he's not well, he's got a virus. Okay, he's still not complaining of fever, and he gets worsened in his manifestation. You're right. I'm putting further brake on your thinking. And you would have said that a 6-year never has a primary malnutrition. It's always secondary. It's a primary malnutrition that presents suddenly with a small trigger, a small excuse. If this is so, then it has to be a secondary malnutrition.
So what is primary and what is secondary? What is this concept of primary and secondary malnutrition?
Like low stores from the beginning, like in preterm babies or low birth weight.
So primary would be more of a nutritional deficiency, and secondary would be due to some chronic disease.
Very good. So secondary is secondary to a systemic disease in the body. Okay, and primary is just lack of food. Okay.
And same is the answer why it is not acute on chronic. Had it been a liver disease, possibly he would not have been very normal child. But without knowing that, we keep all options open, acute onset renal disease or acute on chronic liver disease. Because liver disease, chronic liver disease could be reasonably asymptomatic, except that he's not growing well, he's not active, okay, he's not picking up weight, he has a little loss of appetite. But all these symptoms are easily ignored, but not the cardiac. Cardiac symptoms are not easily ignored because he's getting breathless, he has an exertional dyspnea. Okay, at least he would be feeling tired, he would not like to play. But a chronic liver disease could just exist with nothing much of a prominent symptom. So could this be an acute on chronic liver disease? Give a thought, give a thought. I'm sure you have seen many chronic liver diseases. And they never have an acute onset progressive generalized edema. Okay, this is an acute onset generalized progressive. Okay. So to that extent, mainly little puffiness, maybe little edema feet, mainly the ascites, but not massive generalized. So if we knew that this was acutely severe progressive, then it's not even an acute chronic liver disease, it's not secondary malnutrition, it's not cardiac, so possibly it's renal. Now what kind of renal? There is fever, pyelonephritis. Typical, no? Acute renal disease with fever, pyelonephritis. Come on, give a thing. This is very simple. Yeah.
The edema came first, then the fever.
Okay, edema came first is one reason. What is the other big reason?
6 year.
My direct question is, does acute pyelonephritis have edema at all?
No.
Why not? It's also nephritis, no?
But glomerular diseases, they
Very
have
good. So we
edema.
call it pyelonephritis. What is pyelo?
Which
Renal.
part of the kidney?
renal parenchyma, the cortex.
Pyelo is what?
At the region of renal hilum, where all cortex and medulla, these are coming.
So the collecting system of the urinary system, right? So what are the three big areas of anatomy in the kidney? One is, you said, glomerulus, then
The collecting.
tubules, and then the collecting system, right? So pyelonephritis never has edema, right? Now so this is glomerular disease or tubular disease? Why you say glomerular disease? What is the clinical pointer to it being glomerular disease?
Sir, at the level of glomerulus, there is in the basic point like filtration and all osmotic pressure, oncotic, hydrostatic pressure works at the level of glomerulus. Child has generalized swelling all over the body. Means something, this filtration of the renal function of the renal glomerular capillaries has been affected.
No, so what I'm asking is, tubular disease causes proteinuria or it doesn't cause proteinuria? It causes. So why is this not a tubular disease? Proteinuria at the tubular level, that's why edema.
The amount of protein loss in tubular disease is not as much as glomerular diseases.
And
Albumin is a big molecule that is
Very
lost at the
good.
glomerulus.
so the proteins that may be lost in tubular disease are very small in size, whereas albumin is not lost, right? Secondly, so now finally, what are the clinical manifestations of tubular disease? So in which child will you think, oh, this child may have a tubular renal disease? What should be the symptoms?
Tubules are mainly concerned with the reabsorption of certain amino acids, glucose,
Very
and
good.
Electrolyte
Very
changes.
good, excellent.
So,
So
loss of those substances will cause glycosuria, then polyuria, electrolyte disturbances.
excellent. And one more within that electrolyte disturbance? Acidosis.
Acidification.
Very good. Okay, so this is the manifestation of tubular disease.
Two questions. What is the pathogenesis of edema in nephrotic? He has been losing albumin for quite a few days. Okay, why should there be sudden onset of edema? He is losing protein from 15th of October. He develops edema on 1st of November. What happened in this case? Is proteinuria the only cause of acute precipitation of edema in nephrotic syndrome? In other words, pathogenesis. And secondly, going back to something earlier, we said that malnutrition occurs, primary malnutrition in infancy. Why not in later? What is such a great thing about infancy that malnutrition primary should occur in infancy? Is there any other time in life where you can still get malnutrition primary? The other end of life? Okay. Also, but why at that age malnutrition primary is more common? You and me don't get, 7-year-old doesn't get.
Come on, think whatever you can. What is special about infancy and early childhood?
Feeding is a very vulnerable time for feeding. Most of the malnutrition are weaning associated. The child is exclusively breastfed, though there is hardly anything. The child is, so to say, emotionally attached to the breast, and weaning in adequate amount is not done. So breast milk, while breastfeeding is inadequate, supplementation is not being given, or is being given but child rejects it. Often the mother says, "Humne diya, usne liya nahi," because he is sufficiently emotionally attached to the breast, though he is getting nothing there. He is only swallowing saliva. So that is your place to tell the mother that something she should do, so that he just doesn't go on sucking where it's not there. Such a thing does not happen later on, so that crucial period is not there. Or early part, mother's milk is not there. So the child just goes on taking top feed, it is diluted and unhygienic, so he goes on suffering from malnutrition, diarrhea. So mother further dilutes the feeds, thinking that it is dilution, and goes on. So in that part where breastfeeding is not there, it is usually marasmus. And later on, a chronically malnourished child, weaning time will usually precipitate kwashiorkor, but it is not pure kwashiorkor, it is marasmic kwashiorkor. The child has already been undernourished, some event precipitates edema in the child. So we have kwashiorkor, which is marasmic kwashiorkor, and then after improvement they become marasmic, and after worsening they become, so they keep on shifting from one to another, which doesn't happen later on in a vulnerable period of life. So that was one thing. And now pathogenesis of nephrotic. Why should there be edema today when the child has been losing protein for 15 days earlier? Or has he lost all the albumin in one day?
For a while the liver can compensate by producing more albumin.
Liver will compensate in what way? The fellow is losing. No? Liver's job is to synthesize. So when it is available, it will synthesize. That what is already synthesized is lost. The bank is being robbed. The whole money is drained.
So now, say it in undergraduate words. What happens when protein is lost? What happens after albumin is lost in the urine?
How will the body try to, so to say, compensate, or what will body do?
What is the effect of that in the intravascular compartment?
The oncotic pressure decreases.
Oncotic pressure decreases. So then what happens?
So the fluid will try to move out from a low pressure to outside that pressure chamber. So
fluid will extravasate from intravascular to extravascular. Then what happens?
What will body do to compensate?
The body will try to compensate by taking more fluid in intravascular compartment.
How?
There are two mechanisms. One, first the RAS system is activated. Secondly, the liver tries to compensate by synthesizing proteins and cholesterol molecules, VLDL, HDL. These molecules are synthesized in order to keep the oncotic pressure up. So that's...
Yeah. So renin-angiotensin system activated, tries to conserve sodium and water, and tries to keep replenishing the intravascular volume. But the oncotic pressure is still low, so it keeps extravasating and the cycle goes on. There is another theory also, no? What is that?
Due to salt, the sodium-potassium channel, there's a dysfunction happens over there, and more sodium is reabsorbed in blood. Uh, that also causes more of the ulceration.
Yeah. So there's this underfill theory which we first talked about, where the intravascular compartment is underfilled and therefore all this happens, and where there is a primary disturbance with sodium reabsorption, that is the overfill theory, right? So related to this, there was one point. Related means I just wanted to bring it up because many times, go to the next slide. Many times when you all present, you say, so here it is written not associated with decreased urine output. So does that take you away from nephrotic? So all nephrotics should have decreased urine output? The way I am asking, answer is no, but you have to explain. So this underfill overfill theory, where did the overfill theory come from? Because they found that some nephrotics don't have hypovolemia. So if they don't have hypovolemia, then they wondered, okay, if they don't have hypovolemia, why is something happening? So the point is that a decreased urine output will happen only if there is intravascular depletion, which is dynamic in the same child also, and from child to child the degree of intravascular depletion may vary between two nephrotics, right? So that is why that is not a very dependable pillar to say it is renal or nephrotic or whatever. If it's there, you add it. If it's not there, it doesn't bother you, right?
It looks so easy to understand. Oh, hypoalbuminemia edema, but really the pathogenesis is not so very simple, and even there are two theories for that. So we must know the pathogenesis of nephrotic.
Is nephrotic syndrome a nephritis? Or it's not nephritis? After all, nephritis is inflammation of nephrons. And even nephrotic syndrome is same, no?
There is no inflammation. It's just minimal change disease, which is most commonly seen as just effacement of the charges.
In other words, the nephrologist would say that just because of this, you can't bet to say it is a typical nephrotic syndrome. Therefore, call it, this is a type of a glomerulonephritis, mostly the variety of nephrotic syndrome. Because two overlap a great deal. Nephrotic could also have oliguria. Sometimes there could be few RBCs also microscopic. There could be hypertension, because not everything is minimal lesion. So what does it mean? Isolated epithelial disease is nephrotic. Isolated endothelial disease is typical post-streptococcal glomerulonephritis, but both are just overlapping. So in an exam you would say that my diagnosis is an acute onset glomerulonephritis with severe generalized edema, more in favor of a nephrotic syndrome, which means that you are never sure unless you did all investigations. It's like a pneumonia. Okay, does pneumonia have a chest pain or no chest pain? Does every pneumonia have a chest pain? Then why some pneumonias have chest pain?
Which organ has pain receptors?
Pleuritis and the pleura.
So most of the pneumonias are pleuropneumonias, but if the pleural inflammation is not much evident, okay, then the complaint is not pain. But if it is pretty inflamed, then the complaint is pain. What does it mean? The lung parenchyma and the pleura are so close to each other that you cannot separate the two so easily. Okay.
Okay, so now we move ahead. So now there are multiple past episodes. How do you or what are your thoughts about the fever? It was only 1 day or 7 days?
So 1 day, just the child in this episode.
Speak in the mic.
Right. So in this presentation, child has fever just one day prior to the admission.
So after 15 days of edema, the child had.
Yeah, so edema was followed by fever.
15 days of edema and 1 day of fever.
Yeah.
Okay, and you can come to your negative history. So
no history of cola colored urine,
yeah,
and blurring of vision.
Fine. So we saw all that. No inappropriate weight gain is for what?
So the weight gain is due to edema, and that's I want to mention that's not phrasing like that.
Sorry?
Sir, the weight gain of the child is due to edema and not due to any other cause like.
No, but when we say negative history, no inappropriate weight gain, are we pointing to something? Means because I thought this was little, waking up a sleeping examiner and taking you on to, do you think the differential is Cushing's, and then, getting all convoluted. So, don't, means when you are asked on anthropometry, you may say that this weight is due to edema, etc. But putting here no inappropriate weight gain may invite a little trouble. Okay.
All of the cola colored urine it's not a differential diagnosis of nephrotic. Your negative history should be something which will present like a nephrotic. Okay, cola colored urine is not going to present like nephrotic. Or the other things, abdominal pain, vomiting may be a complication of nephritis. I understand that. But no history suggestive of congestive cardiac failure acute. Increased frequency of mutilation and dysuria is again not a feature of nephrotic. So you have to see which can mimic nephrotic rather than pyelonephritis. This that they don't mimic nephrotic, you don't consider them at all.
And also, you will get unnecessary debate about what do you mean by inappropriate weight gain. Even edema and anasarca is also inappropriate weight gain. So there is not really necessary to have X number of no histories.
Okay, so now at the end of this, what is your impression?
So at the end of the patient, the child, 6-year-old male child, normal by birth and development, unimmunized, having generalized edema of renal origin, third relapse of nephrotic syndrome, to rule out subacute bacterial peritonitis, atypical nephrotic syndrome, steroid dependent or resistant nephrotic syndrome.
Okay, so I want you all to debate each differential. So first one is to rule out subacute bacterial peritonitis. So why do you think that is valid, or you think it's not valid? Yes, 15 days of edema and 1 day of fever. Correct?
If it would have been subacute bacterial peritonitis, child would have a high-grade fever spike, not for just 1 day, 2 to 3 days. Child would have some other associated symptoms.
It would present with abdominal pain and vomiting, abdominal features.
So any reason why you put that?
So due to the fever only, because child has severe edema since 15 days, and then child developed fever and presented with fever, which was suggesting of some infection is there. And one of the very dangerous infection is subacute peritonitis. So even if child is not having fever, vomiting and abdominal pain, I like to rule it out. That's why I put that.
So means there is no particular reason to suspect subacute bacterial peritonitis. You said that fever in a child with nephrotic, I am looking out for any infection, and in that list, this is one of the list, right?
Yeah.
Okay. Atypical nephrotic, why you think this is atypical?
So because child had edema for a long time, and the child was untreated before also with steroids. So I was looking for if it is something else than normal nephrotic syndrome, is it steroid resistant or some complementary system is involved.
No, so in nephrotic, we means instead of using the word atypical, what is our broad clinical division? Clinical. So in febrile seizure, you say that the features are different, so you call it atypical febrile seizure. In nephrotic, what is your main point which divides into two big groups? Only two groups. Are you looking at the pathology in the microscope to divide into two groups? Steroid sensitive or steroid resistant. That's your clinical grouping. So atypical doesn't...
And may be added to that the age of onset. That also...
All that will help you to decide. So why would you want to call this atypical? He responded first time, right?
Sir, yeah, sir. He can be typically earlier.
Sorry?
Sir, he was on presentation like 3.5 years ago. He was typical steroid sensitive nephrotic syndrome. So I was thinking there might be some changes or progression due to which it can become atypical.
If we consider age, I'll give you three types of nephrotic syndrome. One 1-year-old, another 3-year-old, and the third 8-year-old. Do you think age makes a difference to suspect that this may not be a classical minimal lesion? We don't go by that at all. We will use steroids and decide only by that. But what is your...
Only one word is a 6-year-old child with nephrotic syndrome, or whatever age, and one sentence will awaken you suddenly. And that part of sentence is age. So what will awaken you suddenly?
So what about a year-old or an infant coming with a classical nephrotic syndrome?
Nephrotic syndrome is common more after in the 2 to 10 years. 1 to 10 years is common. Less than 1 year, if child presented with typical presentation of nephrotic then we will consider that it is atypical nephrotic syndrome.
Even in infancy, you will take it as a minimal lesion. Okay, yes. You will have to finally go by steroid sensitive or resistant. I'll take you further down the line. Congenital nephrotic syndrome, minimal lesion. I said infant minimal lesion, at any age minimal lesion, yes, common 2 to 5 or 6 years, first episode. Thereafter any number of episodes. What about congenital nephrotic syndrome? Also of no concern?
Congenital nephrotic syndrome these are of more concern because these are usually associated with congenital like Danish-Dice syndrome or some are associated with ADPKD. So they are of more concern with.
So when do you call congenital nephrotic syndrome? I have many congenital malformations or diseases which manifest any time in life, and I still call it congenital. Okay, congenital heart. Oh, I did not know I had an ASD. It's not rare to have a first-time pregnant woman diagnosed as ASD. Till then, she has been examined by everyone, but it's easy to miss. So, can congenital nephrotic syndrome present any time?
Congenital usually present in the early, less than 1 year, in early infancy only.
Yeah. So, means sir is asking 1 month, 3 months, 6 months, is there something like this when they should present?
Up to what age will you say this is congenital? After that age you will say may be congenital, may not be congenital. So 6 months and under usually you will say likely to be, it is considered as congenital. Okay, whether you call it Finnish type or whether you call it MCNS still.
Does it matter? I said age is not a very important thing. We must give steroids and see what happens. While we are right, our antenna goes up and say, oh, can it be something else? But anyway, what something else is decided only by steroid therapy. So how does it matter? So my other question is, how is congenital nephrotic syndrome treated?
Congenital nephrotic syndrome are steroid resistant, so we give albumin infusions.
Good. They are microcystic disease often and not much the common variety that we see.
Just to complete what sir was bringing out is that age does make a difference in the proportion of cases who are likely to be steroid sensitive. So in your classic age group, whether you call it 1 to 10 or 2 to 8 or whatever, majority will be steroid sensitive, a big chunk. This chunk becomes smaller below 1 year and above 10 years, but they can still be steroid sensitive, right? So you will first always try steroid, and then when it doesn't work, you will further look at the possibilities.
Can anybody talk a little bit about secondary nephrotic syndrome? We always assume every nephrotic syndrome is primary, but we don't even scratch our head, could it be secondary? So what is secondary nephrotic syndrome?
Secondary nephrotic syndrome may be with some other infection like hepatitis B, HBs antigen, HIV, or maybe some drug induced or like IgA nephropathy.
Yeah, so something which is not really we often may not consider that, but we should in our mind consider whether it is likely to be, because then the approach changes right in the beginning. Once upon a time, even congenital syphilis used to be thought as a cause of congenital nephrotic syndrome. So we keep that in mind.
And the secondary nephrotic syndrome may present for the first time with renal problem. And that is the time, how would you suspect that it could be SLE presenting only as nephrotic syndrome? Okay. The rest of it will follow. Any clue on that? You get my point? Okay. The presentation could be first renal only. So again the age and many other things. There you would ask for family history of immunological autoimmune disorders, female, okay, more likely as
if at all.
Now, third he has said is steroid dependent or resistant. So what do you mean by these two terms?
So steroid dependent is steroid syndrome which require tapering of doses of steroid, and otherwise it will get into remission. And steroid resistance is when remission cannot be achieved by the completion of high dose steroid.
So in this child, the previous 3 episodes got better, right?
Yes, sir.
So then we can't say steroid resistant, no?
So sir, I have kept this to rule out because in frequent relapse on other like relapsing childs, they do have tendency to become steroid resistant due to multiple relapse.
That can be in the future. So
Yeah.
just now you should not talk of steroid resistant because he has got better, right?
Yeah.
And like you said, can you just, anyone can improve on his definition of steroid dependent? He gave the concept, but what exactly when will you call it steroid dependent?
Steroid dependence is on either there is relapse on alternate day therapy or within 14 days of discontinuation of steroid therapy.
So important is he responds, but the only problem is he relapses on alternate day or within 14 days of stopping, right? So in this, I don't remember your dates, but they were far apart. They were not
1 year,
15 days here. So means then don't put steroid dependent, because then unnecessarily you will be dragged. Okay, come, let's go
You
to
made
exam.
one statement just now that frequently relapsing nephrotic syndrome may turn out to be nephrotic syndrome. I mean resistant nephrotic syndrome. So to start with, they are minimal change and they become resistant later on, or to start with only they must have been somebody with a different histopathology. Their initial manifestation was typical nephrotic syndrome relapsing. Later on they may become resistant. So what is the truth? A minimal change with relapsing becomes then a maximal change, nephrotic or altered change, or they had to start with only. That means if you do their biopsy when they were minimal change, would you have got a different biopsy at that time?
You understood sir's question, so what's your answer?
Initially, they can be steroid sensitive, but they might be having an underlying different morphology.
Very good.
So to start with only they have a different morphology. If we had biopsied them earlier, maybe we would have picked it up. But because vast number of them are steroid sensitive, a biopsy in the early part of life in a typical case is not clinically indicated. Though in early part of life, every nephrotic used to be biopsied when we were new with nephrotic syndrome, and we did find somebody with membranous and other kinds of things. So it doesn't make him resistant later on.
I think we were talking about this child's fever, which would demand that you be aggressive in finding out what's the cause, which is fine. But can you suspect infection in a nephrotic syndrome child without fever? How do you do that?
If the child is on steroids, then he might not present with fever. He might just present with some kind of lethargy and loss of appetite, lethargy and loss of appetite mainly.
Not doing well.
And a nephrotic without infection is a happy soul. Okay. In fact, he is very happy. Whereas if he is not active, if he has lost appetite, then you straight away start investigating the cause of it.
Also unexplained tachycardia. You see a child who is getting tachycardic but no other reason for it, then also you think about occult infection.
And not this point didn't strike me, but I think this may be a very valid point. And this is likely to be missed, unexplained tachycardia. It reminds me of something else. One child was a case of leukemia and he was in remission, but he developed one-day fever. So I phoned the oncologist and I said, he has one-day fever, what do? I observed it. He just asked me one question, have you done this? Does he have tachycardia? I said, yes. He said, send him to me. Send him to me. That means the onco physician wanted to say, he smelled something is not going wrong. I mean, something is going wrong. So tachycardia, I think it's a very valid point. We should look at, we often just ignore that.
Okay, so let's move on to examination.
Starting with general examination, generalized edema was present, child was febrile, temperature 38 degrees Celsius, pulse rate was 118, respiratory rate was 26, peripheral pulses were held, extremity is warm, maintaining saturation 99 in room air, BP was between 50th to 90th centile, PLR was present and CRT was less than 3 seconds. Child was normal by anthro. On head to toe examination, head was normal in shape and size, periorbital edema was present, ear, nose, mouth are normal, throat was normal, no lymphadenopathy was observed in cervical area, pellar was present, no icterus, upper limb was normal, abdominal distances, abdomen was distended, slit umbilicus, no scar, no visual deformity, scrotal and penile edema was present. Edema was present over lower limb up to the knee, and no clubbing was observed. Moving to systemic examination, per abdomen examination, on inspection, abdomen was distended, flanks were full, no distended veins or scar was observed, umbilicus stretched transversely, abdothoracic movement was present, Scrotal penile edema was present and hernial sites were normal. On palpation, abdomen was tense. On superficial palpation, abdomen was tense. Slight tenderness was present on lumbar area. No guarding was there. No divarication was there. On deep palpation, no organomegaly was found. On percussion, fluid still was present, and on auscultation, no bowel sign could be appreciated. Rest of the systemic examination was normal.
Can we examine the child here?
Yes.
Do you have something to put on the table?
Is no bowel sounds worries you? So, with so much of fluid, you must hear the bowel sounds.
Fluid is a bad conductor of sounds, no?
Is it so? Fluid is a bad conductor, fluid is a good conductor.
Better conductor than air.
Yeah.
So good conductor and still no sounds.
In a pleural effusion, you have diminished air entry. Okay, diminish TVFVR. Why? Fluid is a good conductor. You should have increased VR, increased TVF.
Come on, answer both. About bowel sounds and about pleural effusion.
The denser the medium, the better the conduction of sound.
So what is coming in between pleural fluid and the air going or your sound going up to the fluid? Does it reach up to the fluid? Because of the fluid there is a collapsed lung, and that collapsed lung stops all that TVFVR and it doesn't reach the fluid at all. Unless it is massive, in a small infant, yes, you might get a bronchial breathing also. But otherwise, the lung is collapsed in between, and a collapsed lung does not transmit the sound.
Collapsed lung and the pleural surface together act as reflecting surface of the sound. Whatever little sound still gets conducted, maybe even better conducted, but nothing gets conducted. Most of it is reflected.
What about this?
Now about here.
चलता है?
I think the bowels are deep immersed in the ascitic fluid, therefore we don't get the sounds. Am I right?
चलता नहीं है.
That deep inside and overall fluid is there. So how will you hear the bowel sound? Or the other way around? The bowels will float? Yeah, they will float. That is why you get air entry and tympanic node here, and as you go away you get a hoarse fluid. So bowels should be up. Why should you not get any bowels? Normally you should.
Chalo, we need 1 or 2 volunteers to demonstrate examination. Incidentally, today madam called me up and she said that please insist that you all should present cases where clinical signs can be seen. So even madam was very upset that all these times cases are being presented which are only from the ICU, which cannot be brought here. She said clinical signs we have to learn, and we also have been always saying that, right? So now today is a chance to practice clinical signs. Come.
Does he not look very pale with a hemoglobin of some 4 grams or something? Does he not look very pale with a hemoglobin of 4 grams or something? Looks very pale, no?
Come. Chala ja.
Waxy pallor?
Have some more light here.
exam, talk to the child or talk to the mother. Just say that we are just going to examine, it will not hurt you, okay? Talk to them, okay? And then start examination. Small etiquettes, but I think at DNB it's very important.
So on first head to toe examination.
Because she seems to be not very comfortable with all this.
Head to toe examination first.
Just examine
Just
that.
on
खाली चेक करेंगे, तो कुछ तकलीफ नहीं देंगे उसको. So what are you doing? Hold it close to him. No, you go on doing. She'll hold it to you.
no local rise in temperature, superficial palpation. Then move on to the deep palpation.
Also, you are looking for any tenderness anywhere, right? In this nephrotic particularly, you are also looking for any erythema anywhere on the abdominal wall. Okay, go on. What kind of distension will you describe this as?
This is a uniform distension with umbilicus slit-like, flanks are full, and
okay, go on. He's crying, then talk to him.
on deep palpation, there is no organomegaly. The child seems to be in pain.
Okay. You want to do percussion? Demonstrate shifting dullness. अच्छा ठीक है, कोई बात नहीं, कोई बात नहीं.
I just want you to come near and tell me whether the flanks are full or not. Come,
all of you come.
Just see. We know there is an ascites, so we feel their flanks are full. Okay.
There is flank fullness.
So what exactly do we mean by the word flank fullness? First, let us see where is the flank. We are very basic. Don't feel bad if we don't know. Where is the flank? Someone has to point out. Okay. And fullness means what?
There is abdominal distension. It appears.
We use the word flank fullness. No, means what?
It means there is some distension, some localized.
So the flank, what you showed, has to be convex like this. Then you call it flank fullness. So this looks flat. It doesn't look convex. Right?
The center looks a little full as compared to flanks. Okay, just take a note of that. We know that this child possibly has had ascites, etc. But this is not. If you look at this is like a pregnant woman's uterus coming in the center. Okay, why is that? You get the point? The typical, just demonstrate with your hand.
So see, what flank fullness should have been like this. This part should have been convex here and convex here. That is flank fullness, right? So that seems to be missing here.
So typically the fullness is, this is flank fullness and this is central fullness. You know, you do have a bit of flank fullness, but you also have a lot of the central fullness. I want to bring 2 points on this. He looks to be not very happy. Of course, he may
Absolutely.
not be happy because he's here and everybody is troubling him. But he's not. I asked him what is his name. He did not answer. Okay. Does it mean that there is something else happening in this peritoneum? That there is something changing the shape of this that might favor that there is something brewing up there. Okay. So take a note. This is not a classical this kind of a thing, it is more central thing. So that should really worry about you. In the exam, you will be caught on this. Okay? So just keep a watch on that. And he looks to be not very happy. He has got a 15 days problem. Okay? But he is still depressed and all that. It may be not related to infection, but it may as well be. So I think the shape looks a little unusual as classically it should have been. That's the point we want to make, right?
Come, sit.
Thank you. Thank you.
I just wanted to make a point. I thought that the flank fullness is because of the fluid collecting there by gravity. So when the fluid is relatively not very huge, the flank fullness will come first, because the fluid will go to the flanks and by gravity. As the amount of fluid goes on increasing, in addition to flank fullness, the front fullness will also come. So if there is flank fullness and not here, it will still favor ascites of nephrotic like we see. If there is fullness here as well as, so flank fullness is first to come and this fullness is next thing to come.
Actually, if he percussed, you must have seen that the center was quite tympanitic. So possibly the fluid was not so much. You had to go laterally to pick up your dullness. So which means that what looks like is not all filled with. In fact, you may have ascites free fluid but without shifting dullness. Is that possible? Shifting dullness is classical of a free peritoneal fluid. Okay. But is it possible that it is free but you cannot demonstrate shifting dullness?
Too much fluid.
When there is no chance to shift. And what is shifting? Fluid is shifting. In pleural effusion you don't do shifting, no? Or in a pleural effusion you make him sit, you may turn right, left, no. And in ascites you make him do all that. Is that not a shifting dullness? You don't shift there. So what is shifting? Dullness is shifting. Okay. So how can dullness shift? Fluid is dull only, no? A dull person can't be bright sometime when you turn him on one side, right? So what is this shifting dullness? So that means when you shift the fluid becomes tympanitic. What is shifting?
The fluid goes to the dependent area, and the area which was previously fluid filled will become tympanic, like resonant.
Why? What has shifted there?
The fluid has shifted to the dependent area.
And what has shifted to that other area?
The bowel has
the
shifted.
Bowel sounds, bowel loops.
Bowel has a gas. Okay. In pleural effusion, would there be a gas? Sure. Hydropneumothorax. And in the hydropneumothorax, you will certainly try to see whether there is a change, but not only hydrothorax, right? Yeah.
Okay, so now what's your final diagnosis?
Final diagnosis: 6-year-old male child with suspected case of nephrotic syndrome, third relapse, steroid responsive, typical features in an unimmunized, developmentally normal child, most likely etiology being minimal changes.
But with infection, without infection, what do you think?
Sir, that we will rule out on our investigations.
Yeah, but clinically?
Clinically, sir, without infection.
Why?
Yes, because with infection, with some underlying infection, might be to rule out UTI and peritonitis.
Yeah, so as we said, he is not looking happy, and he is, when we were percussing, he was probably suggesting pain. You were also palpating, you were suggesting pain. So we are not sure, there can be infection, we'll have to look for it, right? So looks like with infection. Okay. Now, how will you investigate him? So suppose he is come to you for the first time, how will you investigate him, and how will you investigate this child? Because in exam, I think this difference you must make, because when your child has already had multiple episodes, you don't have to prove the diagnosis. So you answer, okay, in this child I will do these investigations.
So sir, the child who has presented for the first time, we will with edema, we will like to first we will send CBC, we will send RFT, we will send LFT, and we will look for serum electrolytes. Apart from that, we will send urine routine microscopy, and we will look for urine protein, spot protein, and we will send UPCR with blood culture, and we will send Cox workup, and that's.
I don't want so many investigations. I am very poor.
Okay. So sir, then we will do a Scott urine test, and we will send a CBC, and then urine RM.
What is definition of nephrotic syndrome?
So nephrotic syndrome, sir, UPCR more than 2. There is hypoalbuminemia, which is less than 3, and urine protein more than 40 mg per meter square per hour.
So it's massive proteinuria, resultant hypoalbuminemia, clinical edema, and hyperlipidemia, the last being present sometimes not. So if I have to do only few investigations, I will first prove that it is nephrotic syndrome. So I will do the investigations first for proving nephrotic. So I will do is albuminuria, then you can do only one sample, etc. Quantum of albuminuria, I will do is hypoalbuminemia. Edema is clinically present and may be hyperlipidemia. Then your next set of investigations to find out whether there is any clue for a secondary nephrotic syndrome, and whether there is any clue for complications, and whether there is anything that may decide your line of treatment. So if this is how your investigations you should think of in mind.
Why did you say urine protein creatinine ratio? One sec. Why do you want to do that? Why not do just a urine? You said spot protein, so just a urine protein 1 plus 2 plus 3 plus. That's good enough, no? So is there a difference between that 1 plus 2 plus 3 plus which you check at one point and a urine protein creatinine ratio which you check at one point? What is the difference?
Both should ideally be done on a freshly collected morning sample.
So I am saying that suppose I get 3 plus on that spot sample. Why should I waste the money of a protein creatinine ratio test?
Urine serum create renal function test we will come to know, and the child is always already losing protein is losing in the urine.
No, we are not talking of serum creatinine here.
Also, whether it is a nephrotic range proteinuria or a nephritic range proteinuria, 0.2 to 2 suggests nephritic range proteinuria, whereas more than 2 suggests nephrotic range proteinuria.
So the difference is that when you do just a protein estimation on one sample, that is the concentration of protein in that sample. It is not the quantification of protein. There is a difference. It's the concentration of protein. So 300 milligram per liter or whatever, 3 plus or more. But urine protein creatinine, so ideally your nephrotic range is defined as what? It's defined as how much proteinuria ideally?
It's a 40 per meter square per kg per hour.
So 40 mg per meter square per day or 50 mg per kg per 50 mg per kg.
Protein creat ratio more and
So this is when you do a 24-hour sample, and 24-hour sample in children is very difficult to collect. So your urine protein creatinine ratio is a surrogate marker of quantification because your creatinine clearance is dependent on the weight and muscle mass of the child, right? So that is why this is a marker of 24-hour urine protein. So you do urine protein creatinine ratio and you don't depend only on that. So in a treated nephrotic, when you do only spot urine, you may get only 1 plus, but actually he is throwing out a lot of protein. So that 1 plus is misleading because it depends on the volume of urine passed, it depends on the pH of urine and many other things. The estimation of that 1 plus 2 plus. Okay? So that's why urine protein creatinine ratio.
And I think every sample doesn't have the same amount of albumin passed. So occasionally the sample may be negative for protein and even then he is losing so much. So it is not symmetrical in every sample besides specific gravity, pH, volume, so many variations. So they are not dependable at all.
Okay. So in this child, what specifically will you investigate?
Sir, in this child, we will look for, we know this child is nephrotic syndrome, so further we will look for the complications. So the investigation will send our CBC, then serum albumin and RFT, then urine routine microscopy and urine culture and blood culture. And further, if we cannot find anything, then we will look for the radiological investigation for abdomen to do out notice and also Cox workup.
How will you treat this child?
Sir, we will charge child on high high-dose steroids because child has already received, the child has taken steroids previously, so till the child for 4 weeks, till child get into remission, we will keep child on high dose, then we will shift into ODAD doses.
So do you want to first find out whether he has any infection and treat that infection, or you want to start steroids?
No, we want, first we will find if there is infection, then we will treat that infection, because if any latent infection is there, it will flare up after starting steroid. So first thing is we want to treat all the infection and rule out coughs. Then after
how do you rule out coughs?
For coughs we can do GLG, gene expert from his gastric level child is small, or sputum G, and other things. So we can look for lymph node adenopathy is there, and if we can find some other lymph node is necrotic on USG, and so then we can do Monto test we can do for them.
But we will not take the history for contact, no? We'll do everything, but we won't take the history of contact.
So
if nobody gives, nobody gets. So history of contact is first thing we'll ask. Maybe in the recent past, maybe 1 year, 2 years, it may reveal, it may not reveal. But I'll start with history of contact. Okay, then the other things will come.
Should you not rule out every infection? Okay, why only TB? I should do a throat swab, blood culture, urine culture to pick up a symptomatic infection. Like TB also you want to pick up a latent infection, no? So don't you want to pick up a latent streptococcal throat infection, latent urinary tract infection, latent bloodstream infection?
TB is the latent infection which gets reactive, like the bacilli get reactivated when there is immunocompromise. The other sites there is no latent infection. There could be, there is no latent infection, there is no latent bloodstream infections in UTIs.
So what you mean is that we are only looking for a latent or symptomatic infection. If you have got a streptococcal throat infection, okay, not the commensals, then you are symptomatic if you have a urinary tract. So my next question is, should you treat asymptomatic bacteriuria? 10⁵, E. coli, okay, patient is asymptomatic. Should you treat or not treat? Good. You feel you must treat. She feels you must not treat. So just talk to each other and leave it.
If the child doesn't have any urinary symptoms and there's a culture that they have collected which has stayed out and then it showed a growth and the routine is normal and all these things, then we will not treat infection unless they have.
In a nephrotic child, he may not manifest the symptoms. Positive culture, usually we should treat in a immunocompromised patient like nephrotic syndrome who has received multiple, he's received steroids in the past.
So in an asymptomatic bacteriuria in a normal child, you may watch or repeat the sample and not rush to do that. But that is only if you got an E. coli there. But if you got an Acinetobacter or any Pseudomonas or Klebsiella, okay, you will not wait. So E. coli, even 10⁵ and more, asymptomatic, normal person with bacteriuria, you can wait. But this is not a normal child, so you may not really take a call of waiting, and therefore you will have to really look at what it is, right? And therefore a latent asymptomatic infection, common is tuberculosis in our epidemiology. And if you are Manto negative, okay, it doesn't rule out a latent infection. If you are positive, there is a high chance of latent infection. That is all. But suppose this child is Manto positive now. Then you don't give steroids. Or you first treat with 4 drugs and then wait for a while. What do you do?
We'll rule out the infection. The MON2 positive will suggest that he has had an exposure, so we want to rule out the active infection, like by chest X-ray, GL.
How do you rule out an active infection?
Chest X-ray, gastric lavage. So in that case, then we'll give him prophylaxis and we'll start the steroids.
No, I don't think there is any. To best of my knowledge, we don't give prophylaxis before starting steroids for nephrotics, meaning anti-tubercle drugs as prophylaxis. I'm open to correction.
No,
If
so
you have a
that's
disease, you start the treatment for the disease and start the steroids. If there is no focus of infection that you have identified, MON2 or IGRA positive is not enough to start an INH for a patient on this, because he is more than 5 years now here.
I think if you're MON2 positive, you certainly look at contact. Contact, as you said, is any contact of active disease in the past 2 years, or anybody in the family who has been treated for last 2 years. That is considered as contact in the family. Now, in the absence of that, you certainly look at a chest X-ray because that's the commonest one. Okay, and if it is normal, then you consider a risk of not treating versus a risk of treating. So, what is the risk of treating? Under 1 year, a risk. So you may not see. When he is MON2 positive and he is asymptomatic, you have not ruled out an active disease. And you might make a mistake of giving just INH and you might cause a drug resistance. But if it's an older child, if it has been a healthy child, like this child for example, then I don't mind waiting to see what happens with my steroid. Okay. And it's unlikely to flare up suddenly to a point that I would lose the child or I would have a damage. So the risk evaluation would decide what to do, and under 1 year nephrotic is rare, so we will not meet the high risk situation so commonly in nephrotic, and therefore we will possibly start steroids and observe carefully. Okay, if there is going to be a flare up of a latent infection, it won't suddenly go to TBM and cause a damage. It would start showing first that the child is getting sicker, steroid may not work. So we will get some idea. So risk evaluation, in case of doubt, you may risk one way or another after counseling the parents. That would be the right answer.
you want to show the investigations of this child?
The CBC is history of HB of 8 for HCT of 24 and counts at 7,800 and platelets of 5,78,000. ESR was reached 182. OLD was negative. Total protein was 4 and albumin was 1.4. RFT burn was 12 and create was 1.4. Triglyceride and cholesterol were high. Serum electrolyte sodium was 138.3 and potassium was 3.1. And
One sec. Last time also you all mentioned, we forgot. What is OLD?
So, optimal is for malaria and lepto, and D is for dengue. Dengue, NS1, IgG and IgM.
Okay.
And then UPCR was 21.5 and in urine RM 3 to 4 pustles were there. Epithelial cell 2 to 3 and bacteria was present. Urine culture is still awaited. Blood culture is no growth in blood culture.
We appreciate your cryptic language and notations, but not only me, but quite a few messages we get from the net saying that we don't have uniformity in our short form. So this UPCR takes my mind away to decrypt that rather than focusing on this. So you can write UPCR perfectly all right, but when you are reading it out, please tell us its urine protein creat ratio.
Why is cholesterol and triglycerides high in nephrotic? What has got that to do?
Why is it high?
It has a compensatory mechanism by the liver to increase the oncotic pressure.
So increased synthesis by the liver, right? So that means this child is at increased risk of heart disease later. Should we treat him with statins?
It will resolve once the underlying pathology subsides.
So once the nephrotic comes under control, the hyperlipidemia usually comes under control, right? Go on.
That's
Okay, fine. Why was C3 done, sir, is asking?
Sir, to see how the nephritic involvement. Yes, sir.
So should you be doing C3 in every nephritis? Or in which nephritis you might like to do it?
When a nephrotic present, like in a urine routine microscopy, we have hematuria, blood present, RBC present, child has persistent hypertension. So if we are thinking for nephrito plus nephrotic picture.
Yeah, that's an important one to differentiate. I agree. So I was asking for something more than that. One is definitely, you say, in a nephrotic presentation, when you have nephritic symptoms or issues, you go for C3. But in nephritis situation, when would you go for C3 or C3 with something else?
I have a simple nephritis, look like post-streptococcal. Should I do a C3? It is consumed. Why should I do it?
After 12 weeks, you should. You have to see the levels if they have come back to normal or no. So baseline you should have.
Why is that important?
Persistence of hypocomplementemia might suggest MPGN or SLE, and it warrants a renal biopsy.
Very good. Shall we do both C3 and C4? Why only C3? Why partiality? So when do you do C3 and C4 both?
You just said the answer. Say it again.
SLE.
Yeah, when you're suspecting SLE versus PSGN or post-streptococcal glomerulonephritis, then you want to do both. And it's also because it's not just enough to monitor hematuria, microscopic hematuria, which can go on for 6 months after a post-streptococcal glomerulonephritis. But hypocomplementemia, as you said, C3 levels should come back up. Then you can assure the parents that this is still most likely only post-streptococcal and nothing else.
What kind of diet should this child have?
This child should have a restricted salt diet with normal protein.
Why normal protein? Your kidneys liver is working so hard. You don't want to give more protein for liver to produce more protein, even if it means more cholesterol and triglycerides. If you don't provide substrate, then how will the liver produce? It will develop malnutrition.
Until remission start, even if we give a protein extra through the diet, it is going to be lost in the urine.
Excellent. But what is the problem if it's getting lost? You can still give it, no? निकल ही जाएगा और क्या problem है?
The protein itself is.
कम दिया तो और नीचे जाएगा ना?
More glomerular toxicity it will cause.
More hyperfiltration injury is likely with that. Okay.
So restricted salt means what? Means what will you tell the patient? Not to eat salt or what?
I will tell them to eat home made dishes with minimal salt.
Anybody?
Not to add salts in the diet.
While preparing food or while eating? After preparing?
After preparing.
After preparing. And avoid?
Salt, junk food,
You already
preservatives,
said something, right?
papad pickle and
Papad pickle, junk food, ready to use products, all those things have.
Bakery also.
Parle-ji.
Bakery also, yeah.
Because bakery has soda pack.
Can you eat Parle-ji?
I'm a
Sweet
big fan,
biscuits.
be careful.
Parlejis are more salty than sugary.
Okay, all biscuits have a lot of sodium.
And they have soda bicarb, so cakes, all that. Soda bicarb, you know how high sodium, 90 milliequivalents.
If this was a 3-year-old child, what immunization advice will you give?
He's unimmunized, 6-year-old.
Unimmunized.
6-year-old and unimmunized. So tell us his immunization schedule. What will you do?
And if you're in exam, please make sure that you ask history why the immunization was not completed. Okay? It's not enough to know what is missing, but why is missing. Because only then you can take or suggest corrective measures. Okay?
And you know, some high socio-economic, high-low socio-economic, he said, no? High-low socio-economic group is not very low socio-economic group, not a malnourished child. I expect the patient to be reasonably educated. They are educated?
No, sir, they are not educated. But the child was delivered on a private hospital, a private clinic per se, and then child was taken to the village. So that's why, and that village is far away from any medical facility. And they were saying that they didn't know about immunization. The child has to be immunized.
Uncommon, not even immunized at this age is quite uncommon.
Come on, what all will you immunize him against? How will you start? What all will you do?
He is more than 5 years. We will give injection DT and in special vaccine, pneumococcal vaccine.
DT. So you will not give P at all?
Under 7, you can give
Injection DVT.
So DTP. Then
APWP. Capital P, small p.
A cellular pertussis.
When you asked in the exam, always follow UIP. Okay? Only when pushed or asked specifically about IAP or any other programs, you are supposed to know and follow UIP. Okay? So let there be no confusion. If sir asks AP versus WP, unless there is a medical reason for choosing an AP, you have to say WP. Okay? And always include all the vaccines which are available in UIP plus whatever is required for a given condition, you add on to that.
So what all will you give him? DTP you said, then DTWP, then
First visit. Do you have isolated DTPW available? Yes or no? How many of you have given immunization?
They
Not
don't
given.
give.
Correct. No, that's the problem. Most of us come out without giving BCG. We have given more MANTUs than we have given BCGs. That's the problem. So standalone DTPW is not available. So we use DTPW plus HIB plus. Do you give HIB now? Is more than 5 years.
does he need it? Does he need HIV vaccine after 5 years? Come on, come on.
Everybody, please attend on 30th April,
Yeah.
IAP vaccine update. Dr. Rajesh will
So you
guide
please
further on
register
that.
for the vaccine update on 30th April. It is
will
at
be a good
Geo
program.
World Convention Center. So you can also go and see Geo also. But please listen to the vaccines also.
It will be a good program, okay? It's
Yeah.
a day long and
And
should
it's just
be good.
Yeah,
200 rupees, so no big deal. Right?
And interactive.
Yeah. Okay. So, sir, what all vaccines?
Yeah, what all vaccines. And when will you give? I'm going to start him on steroids. Shall I give the vaccine now? Or wait for him to go to remission and stop and then I'll give the vaccine? And which vaccines? Can I give DTP when he is being given steroids? Can I give MMR when he is being given steroids? There's a next door case of chicken pox and a child is on steroids. All these approaches, what will you do? Multiple questions. Maybe answer to them, some of them they will have to find out on
Sir, so when child is on high dose steroid,
what is high dose? Just say that
60
also.
mg per meter, sir.
Or 2 milligram per kilogram per day. Okay.
And
for 2 weeks or more.
On the high dose steroid for initial 14 days, we can give vaccine. If 14 days cross, then for next 4 weeks, we cannot give vaccine during that period.
What happens if somebody takes it by mistake? We are talking about live vaccines, right? We are not talking about inactive vaccines.
DTP and all is no
Inactivated
problem.
vaccines also we avoid because the response may not be adequate. And the same applies for live vaccine also. So even if, as sir says, in emergency you give it or somebody did know and give it, it's very unlikely to cause any problem. Okay, it will not take up. So you may have to repeat it and ignore that vaccine.
Chicken pox contact, child is on steroid. What do we do?
Unvaccinated or vaccinated? Ask no, sir. Ask him, no? Single vaccine taken, 2 taken, none taken. So all this you will come to know on
that.
On 30th. Okay, I'm not promoting. I have no stake in that. I'm just telling you that you all should attend because it will be interesting discussion.
I mean, they will not tell that third month ko DTP de do, 6 weeks ko de. That's not going to be discussed. Something twisting.
If you have to practice pediatrics and if you want to survive, you need to know immunization issues.
This child has diarrhea, he is vomiting and he has loose motions. How will you detect dehydration? There may be no sunken eyes, the tongue may be not very dry, not very easy to make out. He is passing loosies.
Tachycardia.
Yeah. Tachycardia and urine output may be hemoconcentration. Okay, so tachycardia and hemoconcentration will be. What about fluids in this particular child? When will you restrict fluid in a child with nephrotic? And how much will you? Suppose this particular child is passing about 150 ml per day or 250 ml per day is his urine output. You have started him on steroids today. But today the sister tells you that his urine output is 250 ml in 24 hours. What do you do? Or maybe little more than that, but he's oliguric.
You give oliguric fluid replacement. The amount of fluid that is lost the previous day, you replace it. Replace him with that.
That means if he is passing 250 ml urine, we'll give him 250 ml in the next 24 hours.
Plus the insensible water loss.
Which is how much?
400 into blood BSA, body surface area.
So 400 ml per meter square.
Meters.
Okay, so that is the insensible loss. So this will just keep the equilibrium. But the problem is that he is extravasating, no? That's why he is not passing enough.
And he is already hypovolumic. So you are not very happy with a oliguric child who is hypovolumic already, and his steroids is going to take some time for him to respond. You are right that you will restrict fluid, etc. It may or may not work. Gross edema of scrotum, perineal edema.
So
in other words, what is the role of albumin in a child with nephrotic?
So we can start this child on albumin and with Lasix to improve urine volume also and to improve intracellular volume. The albumin will help intracellular compartment to retain more of the fluid.
Yeah, very good answer. I mean, just giving albumin is the best way to waste money, because all that you pour in is going to go out in no time. So albumin is given at that time to increase the intravascular content, because temporarily the fluid will be restricted to intravascular compartment. Then your furosemide will also act better, and it will produce a significant diuresis. So it's an uncommon situation, but it's a typical, little critical situation and not easy to manage. So monitoring urine, weighing the child, those look simple, weighing him alternate day, etc. That will give how retention of fluid is taking place. So once he is on steroids and albuminuria disappears, everything is simple.
From the chat, Dr. Anjali and Dr. Palniraman are actively answering questions. And Dr. Palniraman says urine bacteria present on the report, don't pay too much attention. Try to see it in a gram stain. And also an additional note to that, if you have nitrites reported on a urine routine examination, that also helps in suggesting that there is an active infection rather than just bacteria being seen. Yeah.
So that is gram stain on a freshly voided urine, okay, not later. Because later you get environmental bacteria that get contaminating the sample.
We were talking about a baby having loose motions. So in my place, whenever a baby has severe loose motions, we put a catheter in the rectum and collect the output in a urine drainage bag. When it was not there, we would put an IV set and actually see how many drops fall per minute and replace drop per drop. This happened on 1 year on a 15th August, and that turned out to be cholera. And we replaced him drop by drop, and he survived. And then we presented this nationally and internationally. And my daughter called me from London telling that now they do it like this in London, in UK as well. So we are always worried how to replace fluid. That's how we lose children. This is one good way.
Okay.
One small clue about cholera, of course, may not be relevant. Cholera is watery diarrhea, painless, passing urine like that. But usually painless watery diarrhea, profuse diarrhea could be cholera. Now here management.
He said we'll treat infection and start with steroids.
Anything else which we offer, don't practice, would you like to tell the parents?
Sir, regarding diet.
Yeah, diet and another D? Diary. It is important to keep diary. So in that diary you have on one side protein, secondly how much of steroids is being given and what is the blood pressure. And believe me, even relatively uneducated parents have maintained diary for as long as 1.5 years. And for that you require ideally the heuristics, wherein you measure the urine initially every day at the first sample and later on once in a week. It's not very expensive. The cost is less than a cup of tea per day. And if you have that, it is worth doing that. So treating without diary is not so very good in child with nephrotic syndrome.
Fine. Any other questions? So again, today it's already...
Sir, not a genetic disorder, but it does have some hereditary component to it.
So
yes. Do you counsel them? Yeah, sir. Yeah, we should counsel them for mother who is having second baby. So we can tell her how it's not a genetic disorder. The risk of next baby, there is some risk for next baby to have nephrotic syndrome.
Routine counseling for nephrotic syndrome?
Sir, routine nephrotic syndrome, like it is a cumbersome disease, so they do need motivation because they have long course of treatment and they have recurrent disease, so they need counseling again and again and motivation And
Sir is asking, how will you counsel? Does anyone want to try counseling? Do it as if there is the parent in front of you.
Parent has, we can counsel parent that every child has, right now child has nephrotic syndrome. We are treating, we have to take treatment for 6 weeks.
Madam, what is nephrotic syndrome?
See, I will tell कि this in usual Hindi कि child has a renal problem, that's why he is developing edema.
Madam, what is renal problem? So whenever you counsel, you have to try and use as simple language as possible. Parents should understand, na? So try to modify your language.
Every time like नेक्स्ट टाइम जब भी बच्चे को यूजुअल ऐसे सर्दी खांसी हुआ या कोई भी बुखार आया है तो इस टाइम पे हमने मतलब इस टाइम पे जो ट्रीटमेंट हुआ है तो बार बार बच्चे को फिर से इन्फेक्शन होने का चांसेस है, बार बार फिर से स्वेलिंग आ सकता है. तो आपको भी मतलब इन आवर हॉस्पिटल वी यूजुअली टीच पेरेंट्स हाउ टू डू spot urine albumin test, and we also in front of us we teach parents how to make a diary and how to take note of spot albumin. So usually whenever next time child get any fever or cough cold, any precipitant that can again bring child to the nephrotic syndrome, they have to.
But so see, there is a small difference between counseling about the disease for the first time versus what you are doing is you are educating the mother to take care of the child once she has understood what is the disease. Okay, that's the second part. But first you have to explain what is the disease. Okay, so
I think first thing you identify yourself to the parent that I have been looking after this child and I want to explain you everything. Then ask them which language suits them. Okay, that's the way to start. Thereafter, how do you say it's a nephrotic syndrome? You say that this child's kidney is not working well. And what is not working well? Kidney is the filter. So the filter should have an ability to keep important things different than those who can be wasted. Here, the filter has got some holes. And through holes, something that is important for the body is getting out, and that is protein. So the filter has now got holes, and that is the problem. That's why the proteins are being lost, which normally the filter won't allow the protein to be lost. So they understand this is simple. Now why did this happen? So we say that it is believed, though science doesn't know correctly, but some germ must have entered the body and your defense system, the immune system, started striking at it. But unfortunately, some part of the kidney filter looked like that germ to your own defense system, and even after the germ had gone long back, the body immune system thought that the germ is sitting on that filter and keeps on attacking it and makes a hole. Okay. We don't know why this child did that. This is like abnormal behavior of a normal person. Here is a normal child whose kidney filter is behaving abnormally. So what do you do now? So we stop our immune system from attacking. That's what steroids does. But then with steroids, any other germ comes also, you don't have immune system to fight. So you have to follow my advice correctly, that while steroid is going to make your child all right, the child is also likely to be devoid of a good immune system to fight infection. So you should not allow your child to expose to infection. So hygiene, not allowed to get with somebody who is sick, all that becomes important. Now we will give this medicine for some time and we expect that now the immune system has forgotten to attack. So we give it for about 4 weeks, a big dose, sometimes even 6 weeks, and then we slowly taper, give alternate day single dose, and then over time we stop it. What did we achieve? We stopped the fight. But we are not sure whether this immune system will recollect again wrongly and start fighting again. So this disease may have a relapse, but many may not have a relapse. So you have to now be cautious and keep on monitoring whether there is any change in your facial edema, check urine, and if it's a relapse, then this time I can stop the fight within a short period of time. I don't have to give you long-term treatment. And the relapse will be again taken care of. But sometimes there could be frequent relapses. Then I may have to give a continuous dose. All that, don't worry, I'll keep on explaining you. But mostly we expect a quick remission, a fight is over, your child will be normal, and we will monitor if there is a relapse. But even if there is a relapse, don't worry, we can control relapse, and finally the child will be normal. He will not carry on. But if my treatment does not work the way I want, then I'm going to monitor, and then I may further decide for any further investigation. Chances in your child is that will not happen. In a short time the child will be all right. Thereafter, that the swelling will disappear within a week or 10 days. And you will feel that the problem is over. But don't stop my treatment. Many might tell you that this steroid is harmful. Steroid is not harmful. The user is wrong in using it. I always tell them that you use a knife to cut vegetables or fruits in the kitchen. The same knife is used by the murderer. Knife is not at fault. User is at fault. Steroid is not at fault. I know how to use steroid correctly. So at the end of 4 weeks, I'm going to very closely monitor that there are no side effects. I'll keep on checking your blood pressure often. I may ask you to check the eyes, and I will see that there will be no side effects. And at the right time, I will taper the drug and stop it. But don't stop halfway. If you suddenly stop because somebody told you, oh, this is harmful, it may endanger life. Explain all that, and I think that is what you do that. What did I do? In a simple language, I told them what autoimmune disorder is. Say renal is a filter. Every mother knows what filter is and how the filter gets damaged, and you have to throw the filter away. They understand it very well, right? So try to be as simple as possible, as clear as possible, as detailed as possible. And at the end, don't forget to ask them, do you have any more questions? Okay. Now, I think if you do that, you get the full marks. Okay?
Sir, may I make it simpler?
Yeah, of course.
नॉर्मली अपने यूरिन में प्रोटीन नहीं जा सकता, लेकिन आपके बच्चे की गुर्दे की बीमारी ऐसी है कि बहुत प्रोटीन जा रहा है। यूरिन में इतना प्रोटीन जा रहा है कि बदन का भी प्रोटीन कम हुआ है, इसके लिए सूजन आ गई। उसके कारण बहुत है, वो हमें ज़्यादा डिस्कस नहीं करने। इसकी बीमारी है स्टेरॉइड, और वे हमें देनी है। उससे प्रोटीन कम हो जाएगा, सूजन कम हो जाएगा। आपको वो रोज़ देखना पड़ेगा, फिर ठीक हो जाएगा। लेकिन ये घड़ी घड़ी कभी भी आ सकता है, इसके लिए आपको तैयार रहना पड़ेगा। सो फॉर द टाइम बिंग दिस इज इनफ, देन व्हेन इट कम्स टू रिलैप्सिंग एक्सेट्रा आई विल टेल देम मोर।
This is my lifetime's best counseling I have ever heard. We are all good pediatricians. We do not practice counseling, so we are bad at it. Every patient in ward, you try to tell him about the disease and you will become great counselors. And that is key to success in life.
Okay, so I think we'll stop here. Thank you all our online friends, online faculty, Dr. Palniraman, Dr. Anjali and others for giving their inputs. And we meet once again next Thursday, 6 p.m. for the same teaching session. Thank you.